So a little bit about the way that KRAS is diagnosed. So in order to diagnose someone with KRAS lung cancer, shown here on the far left is an individual's sort of timeline when they present to a medical oncologist clinic. So the first thing we are trying to do is collect a lot of information, and that includes not just the history and physical exam, but an actual biopsy, so an actual sample of the cancer itself. And I've illustrated in the blue box that most people with KRAS lung cancer have non-small cell lung cancer as the subtype. And in order to determine, is it KRAS, first of all, and is it G12C, is it G12D, is it something else? There's another test called DNA sequencing, and that can be either done off of a traditional biopsy or via a blood sample. And so when that is finally determined, which it takes a period of time, it actually takes not just the medical oncologist, but also a proceduralist like a surgeon or an interventional radiologist, or you have to have a blood test sent to a lab. And then that requires both a pathologist, so someone who looks at the cells under a microscope, but also a molecular pathologist, so an individual who specializes in reading DNA mutations. It takes all of those individuals to make a diagnosis of KRAS lung cancer. And that's why we often tell our patients that it takes several weeks before we're able to definitively say what subtype of KRAS lung cancer someone might have. And if it's possible to wait that long, sometimes it's worth waiting to know exactly what it is, because it helps us more personalize the treatment recommendation. So after that, the patient would come back in and you would start treatment. And what I've illustrated in the blue circle is there'd be multiple clinic visits where you would get the treatment, and we would use either the physical exam or scans in combination and laboratory tests to make sure that the cancer is shrinking or stabilizing. Next slide. And then oftentimes in lung cancer, we do see that the cancer grows at some point, and that's known as acquired resistance. And so when that happens, we kind of go through the cycle again, where we think about, would this person benefit from another biopsy? But generally, we have to think about changing the treatment strategy.